Hi everyone, this is Sharon Byron, Marketing Manager for TruCode, and I want to thank you all for joining today's webinar, which is called Integrating Clinical and Financial Processes and Data to Drive Revenue Integrity. And this is presented by nThrive. I am pleased to introduce today's presenters, Denise Johnson and Amy Rector. Denise is Vice President of Process Excellence at nThrive, and she brings extensive leadership expertise in healthcare operations and consulting. She's served as a consulting practice director. She's worked in revenue cycle services for a national EHR company. She's been a manager for a national consulting firm, vice president of health information services for a national IT and consulting firm, and vice president of quality and utilization management for a multi-hospital system. She holds a Master of Science in Healthcare Administration from the University of Detroit. She's an active RHIA and CPHQ. She's presented at speaking engagements on various topics for AHIMA, state and local HIM, and state healthcare financial associations. Amy Rector is Senior Director of Clinical Documentation Improvement and Charge Audit Services at nThrive, a role in which she manages daily operations of outsourced CDI programs for multiple hospitals across the country in charge audit services and technology. She offers more than 10 years of healthcare experience as an emergency and trauma nurse in Detroit and New York City, and she's been working in CDI and managing CDI programs for over 10 years. Amy is the recipient of numerous awards, including 2 electronic medical record awards based on inbox messaging of queries and data mining for CDI programs. She's presented at state ACDIS meetings, including the Michigan ACDIS meeting. She's a graduate of Madonna University in Livonia, Michigan, with a Bachelor's of Science in Nursing. She's a registered nurse in the state of Michigan and holds the Certified Clinical Documentation Specialist certification from ACDIS and the Certified Documentation Improvement Professional from AHIMA. She is also honorably served as Petty Officer 3rd Class in the U.S. Navy for 4 years prior to attaining her degree. So, before I hand it over to Denise and Amy, I just want to thank them for taking the time to present this to all of you today. nThrive is a partner of TruCode, and we really appreciate their time. I also want to review a few housekeeping rules just to make sure we have a successful webinar. Everybody is in listen-only mode, so that means you'll need to use your control panel to communicate. You can find your control panel on the right-hand side of your screen. Minimize it to see your screen better. You can collapse and expand it by clicking on the little arrow in the little red box. If you ask a question, there is a question section of the control panel that's towards the bottom. So you can just enter your question in there. At the end of the webinar, we'll try to answer as many questions as we can. We are going to hold all of the questions until the end, but please feel free to ask a question. I also want to point out handouts are in the handout section of the control panel, so you can download those. The handouts were also emailed to you in the reminder emails, so hopefully you got those. And finally, and most importantly, we want to make sure you receive your CEUs. So tomorrow morning, we'll be sending out an email to all attendees with a link to a brief webinar evaluation. Please complete the evaluation, and once you submit your response, you'll be able to download your CEU certificate. And if you have any questions, you can always email me by responding to the webinar emails you receive, and I'll make sure you get that certificate. All right, so thanks everybody. With that, I'm going to hand it over to Denise and Amy. Thanks everyone.
Thanks, Sharon, and thank you, TruCode, for asking Amy and I to present to the group today. We have a lovely group that are participating. So with that, let's get started. Of course. So you've already heard our introduction, but really what we'd like to cover this afternoon is a couple of things, really starting with regulatory issues that impact healthcare today, a little bit about what is revenue integrity and a description that we think we can use as we kind of level set the audience. Talk for a moment about what are denials and the strategies to prevent downstream revenue cycle issues. Then spend a few moments talking about health information management and how they link to the revenue integrity initiatives within their organizations. And then, of course, we want to cover the CDI link to quality measures, care coordination, revenue integrity, and denials prevention, and show how all of that is coordinated together. And lastly, spend some time speaking about meaningful metrics in which you can manage your outcomes through ongoing data-driven practices. So we'll share some of our experiences with that as well. So some of the benefits, again, are really to understand and hope that you leave today's session with some strategies to mitigate denials in your organization, understand how clinical and financial information and those relationships can drive meaningful outcomes and success, and really spend a little bit of time, again, speaking about some denial prevention strategies that you can deploy in your organizations. So with that, let's talk about some regulatory issues that affect revenue integrity. So not a day goes by, I don't think, that any of us don't see in our email, if you're on any kind of listservs, around things that are happening relative to healthcare regulatory changes, and especially with the middle revenue cycle. Really feel like this is the backbone of many of the emerging trends we're seeing in healthcare, whether it's related to risk assessments and claim submission. It's really critical for organizations to capture every dollar, and once you capture it, ensure that you keep it and have strategies to prevent denials and issues that may arise post claim submission. When we're talking about utilization and how you can use that denials information, there's a lot of things that organizations can do to address regulatory compliance. This is a survey, again, it's a little dated. It was taken back in February of 2016 that speaks to an ICD-10 benchmark. Again, I think folks were concerned at the time of ICD-10 that a huge number of denials would come to fruition following the implementation of ICD-10. What the survey represented, and again, 13 to 15 million claims submitted in that year, they did report 47% of the respondents reported an increase in coding denials, and 58% of the respondents reported a 10% increase in denied claims. So it may seem like a small number, 10%, but when you think about the number of claims submitted in your organizations on a weekly, monthly, daily, basis, that's pretty significant. In ICD-10, we did see the denial rates begin to climb. We anticipated that happening. And what we did show, again, it's a survey back in 2016, was that the 4 major categories of denial types were related to medical necessity, which I'm sure doesn't surprise many of you, and then the unspecified codes, and then hospital and provider, both procedure and diagnoses coding errors. Again, I think those were anticipated, just given the complexity and the level of change that we experience with the ICD-10 implementation, but I think many organizations are still seeing significant denials occur in their organizations, and we'll talk a little bit about the differences between what we saw then in early 2016 and 2017 and what we're seeing today as it relates to clinical validation denials, and Amy's going to speak to that. So what is revenue integrity? I think we hear this word a lot in the industry today. What's the difference between revenue integrity and revenue cycle? So if you think about what is revenue integrity, this comes from this definition comes from the National Association of Healthcare Revenue Integrity. And I think it's important to call it a couple of key concepts that differentiates revenue integrity from, I think, the way in which we think about revenue cycle. Revenue integrity is really more preventive. So really looking at what are the issues that cause revenue leakage and our compliance risks, and what are the things in the organization that can be done through repeatable processes and internal controls, again, focused on prevention of those issues from occurring, and making sure that those practices are documented across the organization. So not only documented, but communicated. So I think from the standpoint of the difference between revenue integrity and revenue cycle, I think the 2 key concepts to keep in mind are the prevention of the recurrence of issues once those are identified, doing some root cause analysis on where those identified areas exist and what's causing them, and then what can you do as an organization to put into practices, processes, and internal controls to prevent them from occurring in the future. So what is denials management, and what are some key strategies that you can utilize in your organization to prevent denials? Denials are going to happen no matter what. We see them in a lot of different areas. but what are some things that you can do and take away from this presentation today as we go forward? So I think everyone knows what a denial is. It's basically when a payer refuses payment for any reason, and it seems like they come up with a lot of different ones every day. Just when you think you figured it out, they seem to come up with another opportunity to deny payment for the organization. And this is an extremely burdensome process administratively to manage those denials. And why is it such a problem? Obviously, it inhibits cash flow for the organization, and it can contribute to the organization's write-off. So as an example, if there's a claim that's a small dollar, it may be easier just to write the claim off versus trying to appeal every single denial, since there are so many, and some of them are and could be relatively small dollars in nature. It will drive up your days in AR, and will also obviously decelerate your cash collections. And so all of those things in combination really erode the profitability for the organization and impact the healthcare system's bottom line. And as we know, most organizations today are operating on pretty thin margins, and so every dollar matters. And so having denials erode the profitability when the margin is already, in many organizations, very small. It does pose significant challenges. So why denials? Again, I'm not going to read this slide, but a couple of key call outs here, I would say. So with $3 trillion in claims submitted, 262 billion are denied, averaging $5 million per hospital. This was a survey done by Change Healthcare back in 2017, and this is based on initial denial data. But that's pretty staggering if you think about it. So $5 million per hospital, already operating on thin margins, is a pretty significant contributor to impacting their bottom line. The other thing I would call out is 65% of claims denied are never resubmitted. So remember when I mentioned earlier about write-offs, 65% are sometimes just written off because of the administrative burden to the organization or lack of resources to combat those denials from the various payers. So I think those are a couple of key things that we see, and the average denial rate is between 5 and 10%. So oftentimes when we go into organizations, it's interesting, some organizations don't even have the ability, just because of the disparate systems in their organization, to really even understand what their true denial rate is. And denials come in all shapes and sizes and in different areas within the organization. So really understanding collectively what the denial rate is sometimes a challenge for hospitals today. So there is two simple truths about denials, which I find, again, a pretty interesting statistic. 90% of denials are preventable. So if you think about the earlier comment I made about the dollars that are written off and the dollars that are required to be appealed, 90% of them are preventable. So if you think about revenue integrity and the focus being on prevention, why are we still seeing the trend in the industry where we see so many denials? And of that 90%, greater than 60% are recoverable. So if you think about the life cycle of a claim, by the time it gets denied, you appeal it, and then you get those dollars recovered if you do in fact appeal it. There is a lag in that reimbursement to the organization, especially if 60% of the ones that are denied are recoverable. So a lot of wasted administrative time in an organization if the approach is not preventative versus reactive. So how does health information link to revenue integrity? Well, from a recent survey from HFMA about the importance of clinical documentation, that was absolutely the highest priority identified by CFOs who took this survey. So improving the accuracy of the clinical information was really felt to be an important issue by the CFOs to meet financial performance targets that they had in their organization, followed closely by decreasing denials. So both of those are obviously important and part of why we want to talk today about integrating the processes of clinical documentation and denial prevention. And the others, as you see, are protecting against RAC audits, which really are denials, as well as improving compliance with DRG coding requirements. So denials occur and should be prevented throughout the cycle. So there's lots of opportunities along the revenue cycle stream where denials occur. So beginning with scheduling, obviously, missing an authorization, missing medical necessity requirements, not identifying a pre-existing condition are just a few. Then you move into patient access or registration, where again, eligibility issues may occur, authorization again, and that's where the documentation challenges start to come in, when you might have wrong information around the demographics, wrong information around the payer, not receiving coordination of benefit information, etc. Then we move into patient care, again, focusing on medical necessity and documentation. But here's really where we want to focus the remainder of our conversation today, is around the middle space, whether it's HIM or charge capture, and looking at documentation, which is the basis for everything. I like to refer to it as the critical middle, where all the documentation resides and supports the ability for a coder to code the charge or code the account correctly, but also ensuring that charge capture is there, and then that the orders are substantiated with medical necessity as well. And you might think that's not important given a DRG reimbursement environment, but you will find that there's still lots of opportunity and importance that we need to place on charge capture accuracy. And then lastly, the billing, which obviously if everything's done right in the front and in the middle, the billing, all that rework that's done in the back around appeals, resubmitting claims, that should, in a well and highly performing organization, be minimized. So there are some challenges, especially with complex denial management. It's extremely resource intense, as well as requires significant expertise in this area to understand all the intricacies of the contracts, what payers pay for and won't pay for, and the denial information, obviously by third-party payers, isn't standardized. So the codes that come back on the claims for the denials vary by payer. And so it makes it extremely challenging, especially if you don't have a way to manage this information electronically. And there's a perceived inability to capture the denial data. As I mentioned earlier, some organizations don't have a robust denial management system, and so they have information that may reside in various departments across the organization. Some may be managed and monitored by the HIM team, others by your clinical, your care coordination team, and then others may be managed by your patient access or your front-end team, as well as the back end when you're thinking about the denials that are coming through. And the information constantly changes. So when you think you figured out what the payer's looking for, they seem to change the rules. And the appeals process in and of itself is very challenging. It's time consuming, understanding the different levels to go through, et cetera. So makes it a little challenging. So I'm going to transition over to Amy, and Amy's going to talk a little bit about CDI's role in denials prevention. Amy?
Thanks, Denise. Good afternoon, everyone. So let's start off with the CDI's role in denials prevention. The majority of the CDI's focus is in the middle, concurrently reviewing the chart, trying to get the clinical support for your top denial topics. Getting the supportive clinical picture, any missing, getting conflicting documentation validated, clarification of coding. So we work mostly in the middle during the concurrent process. Next slide. Thank you. So as I said, our only opportunity to really demonstrate the quality of care is in the middle. And it's also the clinical documentation team is the only people that can really get that during the stay of the patient. And nurses always say what has to be documented if it was done. And that's where we focus. The CDI has shifted the denials. We used to look just for MCCs and CCs. Our programs have grown. Now we're getting more diagnoses looking for clinical support of principal diagnoses, such as sepsis, respiratory failure, malnutrition, renal failure, and congestive heart failure. These are some of the top denials that we're seeing. And we're also making sure we get clinical support for these using SOFA criteria for sepsis, maybe sepsis 3 criteria. Your hospital may not accept SOFA 3 criteria or sepsis 3 criteria, but you have third-party denial payers who are denying based on that. Respiratory failure, really looking, is the clinical picture supported for respiratory failure? Failure meaning stop, right? So is there just 2 liters of oxygen? Was that all? And then in the assessment, the physician just writes that they're playing cards. So are they really in respiratory failure? Malnutrition, severe malnutrition is a huge topic for denials right now. It's easy pickings. So making sure that that person is severely malnourished. And what does that mean at your facility? Renal failure, they're looking at the baseline using that KDIGO criteria. And congestive heart failure has come up recently as being one of our big denials. They're denying the sequencing, making it a secondary instead of a principal. So really looking into that. Collaboration with coding and case management is also vital during this period to make sure you're getting the necessary documentation. One of the things I did want to bring up that we don't have a slide about is the new proposed rule coming out and the possible downgrades of a lot of CCs and MCCs. Severe protein malnutrition, they're considering taking that down, as well as BMI, CKD. So these will all have an effect on what is denied. So the next is a case scenario that I just want to talk about and how this might be denied, or in my opinion, it will be. This is an 88-year-old female with a history of esophageal cancer. She comes in, she's got nausea and vomiting. She's moved to the observation for a consult, and she gets an NG tube placed, and they make her inpatient. Clinical supports the diagnosis of malnutrition. However, the documentation only reflected dysphagia secondary to esophageal cancer. They never wrote malnutrition. So the CDI does their job, and they look at things in the chart, and they look at the clinical support, and they say, it could be malnutrition. So they send an HEBA compliant query for malnutrition as their expected response from the physician. The physician comes back and he documents severe protein malnutrition, and that happens a lot. We expect a diagnosis, but we have to give them the options. So if you look, your 328 was your pre-query DRG, and that is a reimbursement of about $9,000. And then it had no CC or MCC on it because they never wrote malnutrition, which is the CC. And then because the physician wrote severe malnutrition, protein malnutrition, you're going to get an MCC, 34K, which is great. CDI, I think that's a great win. But if you look closely, there's no labs to support. We often need like albumin less than 2.1, and as Denise always said, insurance companies, they'll work it the way that will work for them, I guess you could say. So they may ask for labs, or they may not ask for labs. If you did labs, they might not support it. If you didn't do labs, they'll say, why didn't you do the labs? So looking for TPN, what is a severe treatment for severe protein malnutrition? Yes, we got a PEG tube. There's no nutritional consult. So really then going back and getting the physician to document more, finding more information that would clinically support severe protein malnutrition and reflect the severity of this patient.
Thanks, Amy. So if we talk a little bit more about information and how it links to now shifting to the value-based care model, it's really important that we focus again on revenue integrity and reducing compliance risks. That will be the as you look at the value-based model. So what do we mean about a comprehensive revenue integrity program? So if you look here, whoops, little click happy. So if we look here, you'll see that we talked a lot about coding and CDI, denial prevention, but some other key components of a comprehensive revenue integrity program in your organization would also include, and I alluded to this a little bit earlier, the charge capture and audit process, as well as CDM review. So any organization that's looking to have a robust revenue integrity process would make sure that they have ongoing charge capture auditing being conducted, coding audits, which I think most organizations have done for years. And whether you do it internally, it's always prudent from a compliance perspective to have at least annually an external review conducted of your coding practices, especially if you want to make sure that your auditing is compliant. And then the third piece is also to perform an audit on your CDI practices, ensuring that queries are compliant and that the CDI are capturing the appropriate information and not leading. And so I think if you look at those three components, also including a CDM review, and then lastly, patient status. There's been a lot of denials occurring when you see patients in observation status inappropriately placed or placed in an admission as an inpatient without an order. So all of those things, as you're thinking about creating some preventive strategies in your organization, looking at those policies and procedures that you have, and the way that you're looking at that really encompasses those 5 categories of within the organization. And then lastly, getting input from your contracting team. So working very closely and collaboratively with your managed care team internally to understand the details around what's within each and every one of those contracts so that you're knowledgeable about what they're going to deny, and then coming back to them and having those conversations and meeting with them routinely when you do get denials, including those payers in those conversations. If you look to the value-based reimbursement models, a lot of focus obviously is incentivizing organizations for the quality of care. And that is all going to be based on what's documented in the medical record. So as Amy alluded to, if you're getting a lot of clinical validation denials within your organization, you might want to identify where those topics are coming from, what kinds of denials are you getting, what conversations are you having with the providers, and does it go back to what's within your managed care contract? So helping kind of bridge that gap between what you're seeing in the documentation, clinical validation denials, as well as working with your care coordination team and really understanding the things that are happening, especially with respect to those top 5 things that we see across this across the nation as the top denials for clinical validation. And it also pressures providers really to manage the clinical and financial data convergence. And I think for those of us who work in the middle space, whether you're in HIM or CDI, I think this group is uniquely positioned to really be the best because they do understand both that clinical information, what's documented in the medical record, but also understand the financial data and understanding, making sure that the documentation provides the right care from the right provider at the right value. And there'll be continued emphasis, I'm sure, in the future on these value-based reimbursement models. So how do you leverage the value-based model opportunity? It really does boil down to what we've been talking about for the last several minutes related to clinical documentation. It's the only opportunity really to demonstrate that quality of care was indeed provided. So what's the link now for CDI? So Amy, you want to talk to us a little bit about how it links to quality, et cetera?
Sure, thanks, Denise. So CDI is linked to quality measures, care coordination, revenue integrity, and denials prevention. So first, let's talk about quality measures like PSIs and hacks. Next slide, please. Thank you. So right here we have the PSI 90. You're all probably very familiar with. Post-op respiratory failure is a high target, and we take a look at that to make sure that we have the proper linkage as CDI, but also is it appropriate? So was this patient open heart patient, and 4 hours after surgery, the patient's on the ventilator and the doctor writes post-op respiratory failure? Well, I would expect the patient 4 hours post-op to be on a ventilator. So really going to the doctor and talking to him about, is this really post-op respiratory failure? This is going to hit as a quality issue. Can we talk about this documentation, and educating him, linking things, linking diagnoses to these PSIs, getting clarification if needed. Also POA, were they present on admission? So really working with the quality team to find out what the PSIs are at your facility, and then how you can help improve the documentation. So we want to create benchmarks. Like I said, work with the quality department, figure out where your issues are, strive to meet the, take the top 3 and strive to educate on those. Driven workflows, educate staff, educate the quality department. A lot of those ladies and gentlemen do not know about CDI or what we actually do. They think they do, but teaching them about clinical documentation and how we can help them, as well as the physicians or the nurses on the floor. Nutrition, we often educate wound care. Performing PSI audits. So in your annual audit or your biannual audit with your CDI teams, besides looking at, are you missing any opportunity? Do you have compliance with AHIMA for the queries? Are you entering your data correctly in the tracking tool? Your auditor should also be looking, are there any issues with PSIs and quality? Is there something that the CDI could have clarified concurrently that would have improved the documentation? Looking beyond CDI, working with the coders, and also UR case management, so on PSI documentation. So collaboration with coding and CDI leadership, educating them. We have the new, well, we say it's new ICD-10, but it is. ICD-10 is the coding. That's what they need to know. How do they need to document to be the most specific? That is the reviewing any trends in DRGs or APR discrepancies or denials, pulling your top denials, taking those denials back to the top physicians who are getting denied. If you really looked and analyzed your denials, you'll come up with Dr. Joe is getting denied on malnutrition the most. It is very helpful, we found, to actually take those denial letters back to those doctors and have them read them and ask them, how would you like me to fight this? This is all you gave me in the chart for documentation. Now, he may say there's a whole bunch of other things there, but it wasn't written, it wasn't documented, so it wasn't done. So explaining to him that he has to put that in there. Best practice, all hacks should review pre-bill, so continuing to do that. Looking to make sure clinical indicators for common targeted CCs, MCCs, and principal diagnosis by RACs or third-party payers, taking a look to make sure those are clinically supported is key. All DRG denials accepted by the facility are reviewed. They should all be reviewed. As Denise said, I believe it was 90% are preventable, but 60% aren't even denied or looked at. So the third-party payers, they expect the hospital not to look at them and just write them off. So if you increase your denials review, it may help as well. Validate process of CDI diagnosis and coding summaries align. That's really the validation process. So this is really the clinical documentation integrity model and how it hits numerous departments. So first you have the inpatient encounter registration, making sure they're in the right type of registered correctly. Patient gets in the house and they have the clinical documentation team is working on them, as well as UR, case management, making sure they meet medical necessity, making sure interqual criteria is met. CDI and case management should really work hand in hand, making sure that that DRG is in a system that the case managers can see for length of stay, trying to keep that length of stay down. ICD-10 coding, CPDs, coding, making sure that coding is correct and everything that the CDI clarified, queried for, got coded. Compliance, making sure those AHIMA compliant queries are being issued. Quality collection reporting, so looking at those PSIs and hacks, and then taking everything all together in management, looking at all the informatics and analytics and seeing and tracking, trending. Who's our doctors that we need to educate the most? What are the topics? So really using your information that you've gathered. So this slide is, what does success look like? Denials mitigation through clinical excellence. So we can do this by improving coding accuracy, documentation turnaround times, getting that documentation faster and concurrently, 100% of initial reviews with follow-up reviews, Your query rate, are you querying for just DRG change, MCCs and CCs, or are you querying for these quality issues that may not change the DRG, but it really is going to improve the documentation and make it more robust? Additional CCs and MCCs? How are your physicians responding? If you have a 40% physician response rate, you might need some help from administration. You should have physicians should be on board with this, and you should see, not saying you do, but a decrease in physician being queried. So if you're querying the physician for the same thing over and over and you go and educate him, he should be able to write that on his own. Avoidable days, reducing the ALOS, and then reducing the hack penalty by getting that documentation for quality. So I'm going to hand it back over to Denise.
Nope, I think you're going to cover the metrics.
Or maybe I'm not. Alrighty, thank you. So the next slide is the metrics. I'm talking about better management of outcomes. So looking at, there it is, operational metrics and monitoring data. So when we're looking at analytics and we're looking at the data that the CDI use, case mix index, you hear all about case mix index, medical, surgical, and overall, looking at it month over month and year over year. But query rate, to reflect the medical staff's compliance, making sure they're documenting what you've asked for, it's clinically supported, getting help from a physician advisor or administration if you have a physician who is not compliant. Physician response rate, agree, disagree, no response. We have added unable to determine to our queries. There's just times when physicians cannot say, they're not sure. So unable to determine is an okay answer, but then you also have physicians who use that as, hey, it won't be a no response because they know we're tracking and trending no response. So they start just clicking the unable to determine box instead. So monitoring that, is there one physician that's doing it all the time and looking at the query going, what could I possibly have added for him to be able to say this is chronic CHF? I've added every clinical issue possible, but he still couldn't answer. Taking it back to him and saying, what is missing? Why couldn't you answer this? A lot of times you'll find out that he was just in a hurry or a rush. MCC-CC capture rate, comparing it to MedPAR and other hospitals. Where are you sitting with this? Are you at the 60% medical, 40% surgical? Or now with how hard it is to make a patient inpatient, should it really be 70-50%? Should you have a higher MCC-CC capture rate? And then what are your top queries? What are your top DRGs? Have you had service lines change? Have you had physicians leave? So taking a look at all those things. Next slide, outcome data for denials prevention. So driving education using the EMR. Query topics, the physician, you have utilization of data through the EMR, templates, smart phrases, length of stay by DRG set. So updating queries as needed as well, and then validating results. Why validate your data? So you want to report accurately. Everyone wants to report accurately. You don't want to over-report and then figure it out and have to explain why you were reporting that you made more money than you actually did. So making sure that you use the reviews to determine if the program is successful, but also making sure it's accurate. Looking at trends and investigating. Are we adding payers? Do we have declining review rates? Have we provided a ton of physician education and that is why the query rates went down? Or the physician response rates are going down because you have physicians on vacation or a new physician group has come in. So the next is confirmation of diagnosis and coding. So validating, again, what we have as CDI against the coding summary is critical. If you query for something and it's not coded, it means it doesn't get billed. So validating your principal diagnosis was the same. This is commonly called mismatch. Looking to see if the complication codes were used appropriately. Was the query initiated? Was the answer coded? If it wasn't, you need to get it on the coding summary so it gets billed. Is your sequencing in line? Do you think that there's more clinical indicators or reason for admission after testing was being driven more towards CHF than cellulitis. Why did the coder sequence how they did? Missing MCCs or CCs, making sure you have the correct hacks, POAs on your hacks, and then quality query for queried diagnosis for quality, no DRG change. These are those extra MCCs and CCs that if a denial came in and they took away one diagnosis, an MCC or CC, one that you queried for would fall into its place and there'd be no change in the DRG. So that's critical with denials. The validation process is really, the chart is final coded. The CDS looks to agree with the diagnosis and make sure that query was coded, like I said. The CDS reviews the DRG to make sure that their query made the impact, if that's what they're reporting. If there's additional CCs or MCCs on the case, if they didn't put that one query out, it was still going to the same DRG. So it's a bummer, but you shouldn't take credit because it would have gone to that DRG anyway. CDS modifies the DRG to reflect the true impact. And then the query reasons. Sometimes it's initially DRG change, now it's quality, but tracking and trending those with your informatics and your analytics to see how many quality queries you're doing based on versus your DRG query changes.
Yeah, I think as Amy said, it's really important that that validation process exists. And the reason is you want to make sure that you've got your clinical and your financial data matched. And so it's critically important as you look at comparisons of other like hospitals, whether you're looking at your leapfrog data, your complication rates especially, that information's all public information. So looking at complication rates and your hack rates, again, those can impact reimbursement for the organization, as well as your mortality rates. So one really good example that I like to share is we were called into an organization to evaluate their documentation. They had appeared on the front page of their local newspaper because of their mortality rate. So, you know, this hospital was identified as being high mortality rate against their peers in their community due to pneumonia. So we evaluated the documentation in the charts, and they in fact did not have higher mortality rates based on that population of patient. What they had was inaccurately assigned pneumonia patients to a simple pneumonia DRG versus a complex pneumonia DRG. They did not have a clinical documentation program in place at the time, nor were they coordinated with their care coordination team or their coding team. So when you go in and you look at the documentation, you see a large volume of resources being consumed by these patients. They were very, very sick. Yes, they had expired, but their mortality rate was not any more significant than others in the community. Their issue is really around documentation. So when we talk about, you know, looking at that documentation, collaborating with that whole group of individuals involved in the documentation chain, you know, it's not CDI and clinical documentation is not a department. It's everyone's responsibility along that wheel, and starting with patient access, ensuring that you get the right payer information. Throughout the clinical stay, the CDI and care coordination team should be working hand in hand, as well as with the coding to do that validation process that Amy just outlined. It then will drive accurate CMI data, as well as accurate hack data and accurate MC and CC capture data. All of those things play a very important role in your organization. And the data that's used, both financially and clinically, is also used for research and all other kinds of publicly reported information. So it all starts with what's documented in the record, and the recipients of that information and the whole core for it is because we want to provide great patient care and quality care. And hopefully the reimbursement follows if everything is documented as it should be in the record. So what's needed for success? So I think most importantly, I hope the takeaway for the group is that you really need to have payer and provider clinical data collaboration. And it does require an integrated platform to create those efficiencies between the provider and payer. And so again, if you've got an organization where you're seeing a lot of denial information, you're seeing them trended, and you see a particular managed care provider or other provider payer being identified, work collectively in your organization with your managed care department who does the contracting. Bring in your providers to understand what's happening. Does the managed care provider follow SOFA criteria or not? What do you need to do within your EMR to build out those templates to support those areas of focus so that you have mitigation strategies in place? Making sure that you have robust data that's accurate and there's integrity in the data itself to support process improvement and public reporting. So organizations today use that information. They use coded data for lots of things. They use it for not only public reporting in the quality setting, but also to drive service build opportunities, marketing campaigns, etc. So if you're building it all on data that's not accurate or accurately reflecting your patient population, there's all kinds of impacts that could be identified in your organizations. And lastly, reimbursement maximization. So through denials mitigation, again, avoiding them in the first place, as well as denials management to prevent those revenue shortfalls. No matter what organizations do, you're never going to have a zero denial rate. I doubt, because like I said, every time you think you figured out what the payers are looking for, there's always opportunities for them to change the rules. But if you've got a very proactive approach in your organization that's collaborative, looking through denials mitigation strategies and keeping a process improvement mindset, hopefully you will avoid as many as you can and allow those that do come through and actually result in denial. You have the resources and an administrative team to appeal those that do fall through and end up in a denials experience for your organization. So with that, we try to leave a little bit of time at the end for questions. And so I will turn it over to Sharon, and she can open up the audience for questions if there are any.
Thank you very much. There are a few questions. The first one came up, Amy, when you were first presenting, the first section you presented, and the question's about accountable care organizations and the Medicare Shared Savings Program for risk adjustment that use HCC coding. And those need to be captured at the inpatient setting for the ACO to obtain appropriate reimbursement. So maybe you could just talk a little bit about that in the context of reimbursements, because not all HCCs are CCs and MCCs, vice versa. And the question also is asking about what the effect is on RAF scores.
So the basis of what I was providing was for inpatient only, not HCCs.
Okay.
Yeah.
But I think if you look at, the HCCs and whether or not your organization is training your team, your CDI team, to look for those opportunities, as well as your risk scores, right? Your severity of illness and intensity of service scores. You want to make sure that you're capitalizing on those as well. So there are some tip sheets that you can train your CDI team without going into a lot of detail around HCCs, which is another whole complex discussion. We could spend a whole hour talking about that. There are some things that, certain things that you could focus in your team to identify key areas of documentation. A lot of it does depend on, the whole patient experience for the year, taking that documentation, not only for the hospital inpatient stay, but also what's happening elsewhere in the physician practice, et cetera. It's all that documentation combined that impacts the score, the RAF score.
Thank you. We have another question. Can you please share any insight on best practices for CDI query rates?
Sure. So it really depends on whether you're doing queries for just DRG change or queries for DRG change and quality, which I consider quality anything that doesn't move the DRG, but improves the documentation. So whether it's an additional CC or MCC, improved specificity of coding, validating something that just isn't clear in the record, that when it gets to coding, it will be clear, but it wouldn't really change the DRG. We use a 25% DRG change goal, And then for quality and DRG change, we're looking at over 40%. Now, it also depends, and it will go up and down on physician education. If you're doing a lot of education in a certain month and you're really putting it to them, going to all the meetings, meeting them on the floors, your rates may be lower. Physicians tend, once you tell them what they have to document, they may jump on your bus and they may document that CHF specificity, acute diastolic or acute chronic diastolic systolic for a month or two, but they fall off the bus occasionally, most of them. I think, so continuing to educate, but your query rates will go up and down, but we usually try to hit about 25% and 40% if you're doing both quality, non-DRG change and DRG change.
Yeah, and the other thing I would add to that is that you'd want to track yourself and trend your organization against yourself. So knowing what your past patterns are in terms of your query rate, as Amy said. So if you're seeing an increase or a decrease, why are you seeing those rate changes? And I think the more important measure really is the response rate. So you might have a 40% query rate, but if your response rate is abysmal and you don't have the physician participation, having a high query rate is not going to make or be impactful. The other thing that I've seen as best practice is having a combined view of the query rate overall. So what I mean by that is there's a lot of queries that are done concurrently by the CDI team, but then in the end, there are also a number of queries that are generated by the coding team. If you're really striving in your organization for being proactive and collaborative, it would be a good idea to think about how you might identify and get the query rates for both CDI concurrent as well as retrospective denials, and see if there's any commonalities or trends that you might bring forward. And again, those conversations can take place at your CDI coder team meetings, but also bringing that information, I think, collaboratively together to the providers. So you might be seeing things differently concurrently than you are retrospectively, and I think it's important to have that holistic view of both.
And there's kind of a follow-on question, Denise, for the CDI query rate. Do you have any thoughts on what the expected time frame for a query should be? So, how much time the provider should take with the response?
So Amy, you want to take, we track that today. That's one of our metrics, is the timeliness of response. So Amy, what do you think our best practice is?
Obviously, best practice would be one attempt. We track the amount of attempts. We do the baseball 3 strikes you're out kind of theory, using that as we do give them a couple times, 3 times to try to respond, and then we escalate that. For time, majority of the physicians, I would say over 80%, should really respond after the first attempt. You will find, if you track and trend and look at your analytics again, you'll find that the ones that don't answer the fastest or take the longest time, maybe always on the 3rd attempt, or you have to escalate continuously, would be your same physicians. So maybe getting administration involved to help you improve their response time. I believe the average inpatient admission is 3.4 days these days, around there. So you really, if you're seeing the patient, you have to have documentation in the record. You're seeing the patient at 12, 18 hours into the admission. You put a query out, you have to wait a day for him to come back and round. He may not get back to it before they're discharged. And our real goal is to get that concurrently, get that documentation in the record, so when coding gets it, they can code it and get it out to billing as soon as possible.
Yeah, so it's really within the shortest period of time. And I think, as Amy alluded to, I think another best practice would be to ensure that your organization has an escalation policy that's agreed upon by the medical staff leadership. So I think that's been crucial to the success of our programs, where we've had an escalation policy that's been vetted by, whether it's the medical executive committee, your CMO, et cetera, and you escalate. But it's typically within the first day that you want to get that, because of the shortened length of stay, so that that information is available to the coders at the time of discharge.
Okay, thank you. What percent of CDI programs today involve physicians, or are they a part of?
I'm
Well,
sorry,
best
can you repeat the question? I didn't hear it. I'm sorry, something happened
Sure.
with my computer.
What percentage of CDI programs contain physicians?
I am not sure on the actual national percentage. I have a few physicians that work for me as CDI. I think some places have more, some places have less. Most use nurses, but I really,
Yeah, I mean, it was a question around physicians to do the CDI or physicians as part of the team to support.
So maybe they'll respond with some clarification. To do CDI.
CDI. I'm off the top of my head, I'm not sure, but if you're a member of ACTIS, you can go on and they have an annual survey. And in that survey, they show what the credentials are of the CDI who take the survey. That might help you out.
That's a good thought. All right. I think that's it for questions. Denise and Amy, thank you so much for an awesome presentation and for taking the time to answer our questions. I really appreciate it. Is there another slide at the end that has some information about CEUs before? Awesome, thank you. So I just want to reiterate to everyone on the call, this is a link to a website or landing page you can visit right now. We ask that you participate in a very brief evaluation. Once you submit that evaluation, you'll be able to download your CEU certificate. I'll also be sending out an email tomorrow morning. It will have all this information. It will also have a link to the recording of this webinar. It'll have the handouts. So keep your eyes out for that. You don't need to worry about copying this URL down. It will be sent to you. And if you have any questions or problems, please feel free to send me an email, cbyron@trucode.com. Thanks everyone for joining, and thanks Amy and Denise again.
Well, thank you for having us.
Thank you.
Thanks.